says it blocks the entry of calcium into the nerve cells. Would you kind of limit their calcium intake?
Oh, and that mixes with an amendment that's Manzura.
Uh-huh. What now? I'm sorry, what did you say?
That amendment is Manzura. Is amendment the
I would have to double check. I have it, the memantine is that, with the calcium is the one.
But you said it could be there.
It could go with the acetylcholinesterase.
Yeah, acetylcholine.
That's often with the episode.
Yeah, you don't have to worry about any interactions with those because they're handling it from two separate directions. Okay, so the agitation, we'll go ahead and get finished. The agitation is a big issue with an Alzheimer's client. And you're going to have, remember that a lot of different things can trigger agitation with this client. Something as simple as the room temperature. You are striving for consistency, a safe environment, predictable, and staying on top of their basic daily needs. They may just need to go to the restroom and they're all agitated and upset. You need to make sure if they go to the restroom. Boredom. Never forget to make sure that the signs and symptoms you're looking at may not be delirium. Make sure they don't have something like a UTI going on or they're just dehydrated. A lot of education with the family, if they're not staying with you in the hospital or if they even say are, to help them understand what this person's going through and help them keep the situation at home or in the hospital room calm. Make sure they keep a bottle of water sitting by their bed or their jug of water is filled up all the time. Keep them hydrated. Sometimes they may, keep familiar objects close by. Sometimes they make a memory box for a client with a dementia or Alzheimer's, and it's full of things that they remember, that they can actually remember and connect to, and it helps calm them and gives them a
Is that the ones that are like, sometimes they'll want like a baby doll, they bring a baby doll?
Yeah.
Okay.
Familiar object. And always, always thinking to rule out that there's not something else going on. Don't rest on your laurels. Oh, this patient has dementia. You need to stay on top of those symptoms, and if things change, you need to be making sure you're ruling out an infectious process. You also, just because they have the dementia, you want to make sure you're not missing depression, because it can have a lot of the same signs and symptoms of dementia. And like that one table that I told you about in your textbook compares depression, dementia, and delirium. Table 23-2. You could be thinking that your family member has dementia when really they're just depressed. And a treatment with an antidepressant may help significantly. Treating someone with an advanced Alzheimer's with just an SSRI or just an antidepressant is not going to help significantly. It may help with some of their signs and symptoms, but it won't solve their issue. Signs and symptoms of the depression could be tearfulness, self-deprecating remarks. We'll get into depression more when we do mood disorders. I'm so stupid. I'm just so done. Those self-deprecating remarks. I don't know what to do with myself. Social isolation. No, I just don't feel like going anywhere. Weight loss, sleep disturbances. These are not normal for people who are aging. Just because you're getting older, you shouldn't be seeing these things, and you should be thinking depression. do have a few good slides in here on the medication. But how do you respond to these patients in nursing care beyond managing the medications and all? A few key points. There's some questions in your ATI book that help you with this too, but mainly you want to not argue with these clients. They can easily be agitated. A lot of times they're really scared, so you're not going to argue. You want to teach that to the family. You want to try to redirect them if they're upset, calm them down, but not get into an argument. You want to remember a few key things when you're teaching about these meds, that they're going to do what? Just slow the progression down. You're not going to cure this. There's a good question in ATI. You've got someone that's confused and saying they want to go home. They're in a long-term care facility and they can't leave. The type things you're going to say to them are, you must have forgotten, you are home, you live here. You're not going to say that to them. You can't go outside without one of us. That's not the problem. And are you just not happy here? What's wrong? Why do you want to go home? That's not answering the question or handling the problem. The best answer that they have on here is just tell them, I'm your nurse. I'm going to walk with you back to your room, okay? You're not going to get into trying to convince them to feel otherwise or argue with them or anything. You're going to try to redirect them, make them feel safe. Kind of goes back to that therapeutic communication that we went over in Unit 1, and redirect them back to their room. And then there's also a good question. A nurse is performing an admission assessment on a client who has delirium related to an acute urinary tract infection. Which of the findings would they expect to find? A history of gradual memory loss? Family report of personality changes? Hallucinations? Unaltered level of consciousness? And restlessness? So, yes. I'm sorry. Practicing those ATI quiz questions too will kind of help you work through those differences in your head, okay? That is about it for neurocognitive. Like I said, those last few slides go over the medications a little bit more that we discussed. The anti-anxiety, we talked about you may use a benzodiazepine, preferably Ativan, short-acting. The new group, the acetylcholinesterase inhibitors. They may use some mood stabilizers. Remember we talked about anticonvulsants earlier. These two, Depakote, Neurontin. Atypical and older generation antipsychotics. We've already gone over those groups. So that wraps up neurocognitive.
Ms. Lyons, have you ever seen the movie Death of a Salesman? It's got Dustin Hoffman in it. It was in the 80s, but it shows a lot of the, it shows somebody that's going through it, but it shows like the family watching him, but it shows how he's in and out of multiple places. So it shows the route of somebody that's aging pretty quickly.
Pretty interesting concept. Watched it, just kind of put together, and I've never seen it.
Didn't we have to watch that?
All right, so let's do mood disorders. mood disorders, the biggest one we'll be talking about is depression. And depression is the #1 leading cause of disability in the country. And a lot of what the slides are going over is how we diagnose depression, and the different types of depression. You don't need to get really in the weeds about how it's diagnosed, but you do need to know the signs and symptoms. And then again, pharmacology will be a big part of this part of the unit, but we've covered these meds pretty good so far. So you have a jump on that. See, like major depressive disorder, it gets into must have symptoms present most of the day, nearly every day, for at least 2 weeks, and it must cause significant distress and impair function. We don't need to memorize 2 weeks and all, but you do need to look at this how they diagnose it, I guess, to understand the impact of the depression on somebody. And to kind of differentiate normal, you're going through something stressful in your life or something in your life that's sad and made you kind of depressed. Understanding what's the difference between that and being diagnosed with a major depressive disorder. Again, intensity, duration, and the length of time it goes on. A major depressive disorder, this person hardly has any time that they don't feel depressed. And the depression is impacting their life. It's impairing their ability to function. And like it says here, it's classified according to the severity, the longitudinal course, and the descriptions of their most recent episode. How severe is it? How long has it been going on? How often does it occur? Typically, somebody with a major depressive disorder, their episodes last several weeks to several months, and then they're able to have a relatively normal mood and behavior. Oh, and as far as your syllabus, as we're going over this, your content for this new part of the unit is major depression, bipolar, mania, seasonal affective disorder, and premenstrual dysphoric disorder. So if you see some others popping up, just know they're not in your syllabus. Postpartum depression is when a depressive illness is diagnosed within 4 weeks of postpartum. I don't know if y'all remember when we covered this in level 2 in maternal child, we've kind of gotten away from people calling it, minimizing depression by calling it baby blues. You have a very targeted conversation with your client before they go home, a postpartum patient. They need to know the signs and symptoms of depression, and they need to know they need to call their provider. Don't need to go, oh, that's just normal, everybody kind of feels that way. They need to know to reach out if they have trouble coping, and then reach out. And so what are those symptoms? Persistent, sad, anxious, or empty mood. Loss of interest in their normal activities, including sex. Things that used to bring them pleasure no longer do. Restlessness, irritability or excessive crying. Feelings of guilt and worthlessness and helplessness. Very pessimistic, negative attitude. Just don't see anything good. Their sleep pattern can be affected Either way, they could be sleeping too much or tell you they can't sleep at all. Same with eating and their weight. They could be losing weight or they could be eating too much and gaining weight. There's some demographics in there, but you don't need to really read something like that. You do need to know that studies show that women molested as children are more likely to have clinical depression than those that have no history of abuse. So continuing on with depression, feeling slowed down, fatigue, just can't do anything. They may have thoughts of death or suicide or suicide attempts. Their thinking is disturbed. They have trouble concentrating and remembering things. They have a hard time making decisions. Remember the patient I told you about the other day that couldn't leave her room to go eat breakfast? She just could not make a decision on something as simple as I'm going to go ahead and get finished and go eat breakfast. Persistent physical symptoms that don't respond to treatment, such as headaches, stomach upset, chronic pain. Some cultural considerations. There is some commonality with poverty. You have more stress, more things going on, especially with women, so you may see more in that demographic. And like we said earlier, depression is not a normal part of aging. It shouldn't be a normal part of being a female and having things like empty nest syndrome. Oh, well, that's just normal, you know, our kids will move out. And that just kind of used to be blown off. It's not normal to have these persistent problems. There is more of a risk with a family history of depression, so there is some genetic factors involved. Certainly the biochemical factors, we've talked about that already. That's when we're talking about the neurotransmitters and the treatment. Part of the treatment being treating them and trying to improve the number of circulating neurotransmitters. So they think there is a biochemical impact on what causes depression. Some sort of disruption or dysfunction in those neurotransmitters that handle mood. Environmental and stress, they can lead to depression. Diagnosis with some sort of a devastating disease or a significant loss can impact your, put you more at risk for depression. People who have like low self-esteem, or people who feel like they really can't control things in their life. Worriers, those type people that have those type personalities are more at risk for developing depression. The big takeaway here, if somebody asks you what causes depression, is it one thing? No. So here are our neurotransmitters that we've been talking about since last week. Serotonin, norepinephrine, talks about where they start from. And they deal with brain activity. They're the carriers of the transmission. the messages going from neuron to neuron. And the thoughts are, if they are not doing their job, brain activity is not happening the way it should because the message is not getting carried from nerve to nerve. So that's when you see this CT or MRI here of a depressed brain and a recovered brain, there's more activity going on in the depressed brain, depressed. And so there is some link there with the actual activity of what's going on in a healthy, normal brain. So the thought is you take the medication that helps with the activity, and you should help with the feelings that go along with depressed brain. So how do you manage it? The depression. Several different ways, and these are all things that we've already talked about. Medication, psychotherapy. When you think of psychotherapy, think Freud, talking through it, trying to figure out what's causing it. Cognitive behavioral therapy, just what we went over last week, changing how you think. Interpersonal therapy, working with how you work with others, and electroshock therapy, ECGs. All these things we talked about in therapeutic regimen in Unit 1. So what meds are we going to use? We can use antidepressants, anti-anxiety agents, and lithium. Your 3 classifications of your antidepressants, the main ones, tricyclics, SSRIs, and MAOIs. So on top of having the antidepressants, they may also be given mood stabilizers, trying to level out those moods. Especially as we talk more about bipolar. And we went over lithium in Unit 1, kind of the prototype mood stabilizer for bipolar disorder. Has that narrow therapeutic range and is monitored via serum levels every 1 to 3 days while you're trying to get them regulated on a dose of lithium. After that, every 2 to 3 months, they need to have their levels checked. And this slide, you don't need to memorize it, but you need to be able to think through it. Because we'll get more into these phases of depression. The main takeaway from this slide is you're going to manage depression differently at different phases of where they're at. If they're in an acute phase of depression to the point where they've had to be hospitalized, you may use a tricyclic antidepressant with lithium. You may be using a real high-powered antidepressant, a really high-powered mood stabilizer, and some things to help them sleep. I mean, you see, and then as you move them through it and they get better, you may just have them on one antidepressant, okay? A lot of times in the hospital, when you're on the mental health unit, like when we go during clinicals, you'll see it, a lot of times the nurse practitioner is doing the therapy sessions. The nurse prac is managing the group therapy sessions. And a licensed social worker or another type of therapist is working with them on skill sets, whatever. The only time they may see the doctor in the unit is when they are doing medication management. That's kind of the main role of the physician in that setting is managing the meds, because that takes a lot of time and attention. And so a lot of times the patient, you have longer lengths of stay in a mental health unit. You know, if we bring somebody in to do surgery, they need to be out of the hospital. Like a C-section needs to be out in 3 days. Most and that's about as major as you get. You know, you're looking at lengths of stay constantly. When can we get them home? When can we get them home? Your goal is to get people home. You get a longer length of stay with mental health. Sometimes they're even looking at how come all your patients are, it looks a little suspicious if you've got a mental health unit and you look at your average length of stay and it's 5.6 days. Everybody's like, what are you doing? You're either putting them out too soon or you admitted them when they really didn't need to be in the hospital. Because the thought process is if they were sick enough with a mental health issue and they are admitted,
It can take longer than the 5 days.
it take longer. For one thing, the medications
Take 2 weeks to start.
a lot of the meds take 2 weeks to kick in, you know, so as far as an antidepressant or something. So as we're discussing managing these clients, just understand these hospitalizations, this is not your typical hospitalization. It's meant to take a little while. And so they'll be meeting with the provider, the doctor usually, and saying, well, let's look at your meds. And we brought you in, you were on just an SSRI, but we put you on a tricyclic and all. How are you feeling? And the big questions, are you eating? One of the other big questions of how are you sleeping? You're just kind of going back to those Maslow's and getting them on a routine. And then that's some of the best ways to let you know that the meds are working. Are they talking better? Are they getting up, leaving their room? Are they brushing their teeth, brushing their hair? So this slide is not to confuse you on trying to come up with combinations of how you would give these meds. It really just helps to understand that you are juggling these different types of meds as you're working through the different phases of depression. And that it's not a stagnant thing with treating depression. It's not, oh, we're going to give you this, and that's going to be it. It's a constant monitoring of what's working. And do they need a different combination? You hear it on TV when you hear the ads about some of the different medications. They'll put somebody on even like another class of med, but you know the ad starts off, are you still having symptoms of your depression even after being on an SSRI? Well, then we have this medication. So it's speaking to that need to sometimes mix and match meds to try to handle the different symptoms. So psychotherapy and family therapy are used a good bit in depression. And most often they support the medication. It's good to have the family come in. If you're in these units, you'll see that after kind of getting people leveled out, you'll want to go ahead and try to get a family member in. When can your significant other, when can your mom come in and dad come in and we all do some therapy together and sit down and talk about it. Working through those problems. So another type of depressive order is bipolar disorder. It used to be called manic depression. And the defining difference here between this and, say, a major depressive disorder is this manic phase. I think Dr. Scott was a manic depressive last week in the skills lab. So, manic, an extreme case. But pretty spot on with what you may see. Bipolar disorder has, these clients will have periods of mania. And when we talk about family therapy, you can tell why family therapy is probably going to be important, especially with somebody with bipolar disorder, because if they've been through a significant manic phase, this is where they could have spent all their money, lost their car, ran up a gambling debt, quit their job, got in a fight, gone to jail. I mean, because the mania is extreme, and they kind of feel on top of the world. And then it's the cycle of the depression that comes after it. So it's not just the depression you're looking at. If this person is having the depression signs and symptoms and then having the mania, then you're looking more at a bipolar. So when you're looking at diagnosing it, they have had to have one or more manic episodes. And what you see, like I was talking about, abnormally persistent, elevated and expansive mood. I wasn't in there with Dr. Scott, but I imagine those of y'all that were in, did she exemplify that? She looked like she was feeling pretty expansive. Yeah. Yeah. Feeling good? Feeling really good. Really good. And this is not a quick cycling. This isn't like drug-induced or alcoholism, and you know, where when I'm drunk I'm really happy, and then when I'm hungover I'm sad. We're not talking about this. Is a period they go through, so it's a little bit longer cycling. You need to see 3 or more of the following: extreme mood swings, irritability, sudden attacks of misplaced rage. That's where the rest come in. Sleep disturbances. How long has it been since you slept? I ain't slept 3 days. I'm feeling too good to sleep. I got too much going on. Awakening earlier each day. Inability to stay in bed. They'll start having problems with their work output. This obviously interferes with your productivity. Distracted, restless. This is really hard for family members to deal with when somebody moves into this manic phase. Spending sprees, spent all their money, ran their credit cards up. Sexual promiscuity, woke up somewhere and didn't even know who it was. Or they suddenly find the love of their life and never met him before. Exaggerated self-esteem. Delusions of grandeur. I am super important. It's a delusion.
Like I work for the mayor and the governor, but my best friend works for the governor and the president.
Working for the CIA and security.
Well, no, that's what Dr. Scott said.
Oh, is that what she said? Working for the government?
When there was conventions.
And again, y'all, not making fun, just trying to help you understand when you see it, what you're seeing. And already hearing what I'm hearing. Elation, excessive illogical rhyming, punning, word association, all sorts of speech issues, pressured speech, talking really, really hard. It's very important. We've got to get out of here. I can't come into work today. I got something going on. You know what? If you don't let me call in, I'll just quit. Now remember, this is all stems from a mood disorder that is linked to depression. So you know, you guys, you're seeing what you think you're seeing is superelation, but remember, we're in a mood disorder and depressive disorder. They usually begin suddenly and last from a few days to a few months. So we're not talking about the lability of emotions that you may see with somebody. You know, I've heard somebody, a family member, that we knew the family member that they were talking about had a drug problem, an addiction, struggling with an addiction problem, and they were talking about they thought they were bipolar because they changed during the day. You know, and it was like, no, they went outside and got some drugs, and then they came back and they were happy. And they wore off and they were sad. And they went to sleep. And then they went back out and did some drugs, and then they're happy. That's not bipolar. That is taking a substance that's affecting you. It usually cycles a few days to a few months. You can see where if you were manic for a few months, the destruction you could have in your life. It can take you a long time to recover from one significant manic phase. They could be hypomania, which means just not as high level of mania. You're not going to see the psychotic features and the extremely impaired function. They could be hypomanic. They're not going to end up in the hospital for that. We're talking about with bipolar, when they have this manic phase, they could end up in the hospital. And it's real hard, like taking care of interviewing Dr. Scott. It would take a while to work with her to try to figure out, was she schizophrenic and out of touch with reality, or was she having a manic phase of a bipolar disorder that looks like, you know, she's not in touch with reality. So, she would be glad to know we're discussing her so much today in our lecture. Next, at the end of the week, when we do personality disorders.
Then we'll do you, right?
Yeah. And then the depression, that was Dr. Bell, who did the interview with her, what she was so usually not the psychotic features with the hypomania. It's kind of misleading, hypo and mania, you know, makes you kind of think you're not, but you're just mildly manic. I think most of us
At the
have
beginning
been
of it,
mildly
maybe.
manic at some point. Sometimes it comes in handy, but the manic phase, the true manic phase, is what we'll be talking about. It's also characterized, bipolar disorder is also characterized by a major depressive episode. They may be going through it now, or they could have had one in the past. You need that major depressive episode to come up with a diagnosis of bipolar disorder. So they need to have had at least a at least a mildly manic phase and a depressed phase for you to have this bipolar disorder diagnosis. It is the cycling between the two that defines this disorder. Okay, so how do we medically manage this? Mood stabilizers. Just for the reason that we said, we're trying to take a behavior that looks like this and level it out to where it's normal, where we have our normal little fluctuations and ups and downs. You also use some anti-seizure meds. They also, mood stabilizers like lithium, we said, are prototype, but you can also use some anti-seizure meds that can help you stabilize your mood. Remember, we talked about that in Unit 1. Went over it in ATI. And your mainstay here is still lithium. If they come in and they're really manic, you may give them a benzodiazepine to calm them down, and they will be up and down the hall. If any of you have ever cared for this patient, I don't know. They're going 100 miles an hour. They're busy. If they have extreme agitation and psychotic, out of touch reality things going on in the manic phase, you may also give them an antipsychotic, a Haldol or something, to help them get them back in touch with reality, dealing with their dopamine. So what might you see? The racing thoughts, the flight of ideas, grandiosity. Oh, they're just talking about all sorts of stuff, and flight of ideas are changing subjects a lot. Impaired judgments, they're not making the best decisions at this point. Inflated self-esteem. I really don't. And this is why they end up not taking their lithium. They get on this, they get to a manic phase, and then they're like, I'm great, I don't need anything, I don't want to fool with this, I don't need to go get levels drawn, I don't need all this. This one of the big challenges is trying to keep the mood stabilizers on board so that you can stabilize their moods, because when you get into the manic phase, you feel so good about everything. Talkative, goal-directed behavior. I got to work on this little project I'm doing right now. Can't really do anything else. Can't talk to you. I got to work on this. I got something going on. I got some work going on for the queen. She's called me. I've got to get this done. They're as easily agitated. They don't need to sleep or eat. This is the person you're literally following down the hall trying to get them to drink some water. Here, throw you a bottle of water. Will you drink some water while you're walking? Let me walk with you and you drink this water. Let me give you a protein shake or something to try to get something in you while I'm walking and I'm talking to you. And get dehydrated, sleep deprived. It's going to get to the point that if they don't sleep at some point, you're going to have to try to give them something. And they're easily agitated. So you're not like stopping them in the hall and grabbing them by the shoulders and now look, you need to go back to your room. That's when you just might get like, pow, punched. Easily agitated. One time we were living out of state and my kids were little, and there was a person that lived in the neighborhood that must have been bipolar or maybe schizophrenic, and not quite sure, but my husband and I, you know, we always would see him and he would be friendly, but you would see him talking to himself and stuff, and you couldn't really tell what was going on with him, but the kids knew him too. When we were riding our bikes one day, all of us and the two kids, we're talking about the easily agitated, and he was in a real good mood, had on an Easter bonnet he had made, and it had flowers and all on it, and he was good mood, talking to himself on his bicycle, and we're pulling up by him kind of, and the kids are in. We said, hey, how you doing? Oh, I'm doing good. And he started talking, and I just said, I thought it'd be okay. I said, I like your hat. He went off on us, and my kids' bikes went like separate directions. They were like, and we had to go like round everybody up. He hopped off his bike, and I was like, okay, gotta go. And I kept riding. My husband said, what'd you say that for? I was like, I didn't even think, he had put a lot, you would say that kind of stuff to him because he'd have a jacket or something. He'd say, oh, I like that. Oh, thanks. I went and got it here. You just had that kind of conversation with him in the past. And I said, I like your hat. That didn't go over well. He was in an agitated mood, and it was like that. So you're picking what you say, neutral, not mentioning the hat. But yeah, you got to keep these folks, you're hydrated and fed, and at some point get them to bed. That'll be one of your defining things a week into this. You go back to this patient and see the difference from when they came in and they've been up for 2 solid days. The first 2 days they were in the unit, and you were having to follow them up and down the hall, to now, you can talk to them and they tell you they slept 4 or 5 hours at one time last night. That's a huge accomplishment for the patient at this phase. So their social symptoms of mania: increased sociability. They're out and about, talking to everybody. Intrusive. So you remember when we talked about maintaining the milieu? One of the important roles of the nurse. Managing this client in this stage is going to be key. They may have to just be redirected back to their room. Because they can, they may not be able to come to group therapy until you get a handle. This is not the person that you're sitting down, because remember, especially in inpatient, we talked about it's a very mixed group of people. They're all here for different reasons. They don't know each other, so they're going to be telling some kind of embarrassing things to strangers that you need them to feel comfortable and safe. And then you have this person in a manic phase just going to come interrupt you and get all, past comments about you and, feeling pretty good about themselves. Well, I wouldn't do that. This is probably, until you get them under control, they don't need to be in group therapy. And you don't want to get in the habit of saying, well, Mr. Johnson is just not allowed to come to group. You want them to try to get in group as much as they can. See where some of this might not be conducive in the milieu. And just out and about in the hall. Yep. Out about in the hallways. Because remember, we said we kind of don't want them in their room the whole time. We want them out, walking around. This person, everybody will kind of be steering clear of in these first few phases because they're just walking up and down. You've really got to stay on top of them. Okay, so let's see. We will stop at this and take a break. And